Today we'll be talking about preventing sudden death in sports. There are 10 conditions covered in the NATA statement. These include asthma, catastrophic brain injuries, cervical spine injuries, diabetes, exertional heat stroke, exertional hyponatremia, exertional sickling, head-down contact in football, lightning, and sudden cardiac arrest. If asthma is suspected, the individual must undergo thorough medical history and physical exam. The individual should participate in structured warm-up protocols before exercise and sports. Sports medicine staff should educate the individual about the use of medications, spirometry devices, and asthma triggers. Sports medicine staff also need to be aware of the major signs and symptoms of asthmatic episodes. The utilization of spirometry tests at rest and with exercise are going to be used to help diagnose this condition. For acute asthma, a short-acting beta agonist is to be used to relieve symptoms. If feasible, you will remove the athlete from the environment causing the asthmatic episode. Physical activity should be initiated at low aerobic levels and intensity, gradually increased while monitoring the athletes with asthma. Catastrophic brain injuries. The athletic trainer is responsible for coordinating education sessions in regards to concussion safety. The athletic trainer should enforce standard use of certified helmets. The athletic trainer should also use a comprehensive objective concussion assessment that includes symptoms, cognitive and balance measures. A comprehensive medical management plan should be implemented. If symptoms persist or worsen or level of consciousness deteriorates, refer the patient immediately. Oral and written instructions for home care should be given to the athlete and responsible adult. An RTP progression after head injury begins once the athlete is completely asymptomatic. The athlete should be monitored throughout and after sessions for symptoms. Cervical spine injuries. The athletic trainer should be familiar with sport-specific causes of these catastrophic spine injuries and their physiological responses. The athletic trainer should educate the coaches and athletes about the mechanisms for these injuries. Corrosion-resistant hardware is to be used in the helmets, and the helmet should be regularly maintained throughout and during the postseason. Emergency department personnel should be familiar with proper athletic equipment removal. During the initial assessment, unconsciousness or altered level of consciousness, bilateral neurological findings or complaints, significant midline spine pain with or without palpation, or obvious spinal column deformity all require initiation of spine injury management protocol. When injury is expected, traction should not be applied to the cervical spine. Immediate attempt to expose the airway should be made. If spine is not in neutral, the rescuer is to realign the cervical spine. This is contraindicated if there is pain, neurological symptoms, muscle spasm, airway compromisation, physical difficulty repositioning it, encountered resistance, or apprehension expressed by the patient. The athlete should be immobilized with long spine board or other full body immobilization devices. Diabetes. Athletes with diabetes should have diabetes care plan that includes blood glucose monitoring and insulin guidelines, treatment guidelines for hypo and hyperglycemia, and emergency contact information. Prevention strategies for hyperglycemia are described by American Diabetes Association or the ADA. Athletic trainers must be educated on the signs and symptoms of hypo and hyperglycemia and how to treat both mild and severe cases. The athletic trainer should follow ADA guidelines for athletes exercising during hypoglycemic periods. Physicians determine the safe blood glucose range to return an athlete to play after an episode of hypo or hyperglycemia. Exertional heat stroke. Athletes should be screened during preseason and also questioned about risk factors or history of heat illnesses. Be aware of those wearing protective equipment during periods of high environmental stress. Acclimatization should gradually occur over a period of 7 to 14 days, and a consistent level of hydration and fluid replacement is to be maintained. Athletic trainers should educate relevant personnel about prevention of heat illnesses and the policy and procedures regarding any potential incidences. The two main criteria for diagnosis of exertional heat stroke are a core temperature of greater than 104 degrees Fahrenheit taken via rectal thermometer and central nervous system dysfunction. A core temperature must be reduced to less than 102 degrees Fahrenheit, and cold water immersion is the fastest cooling modality. Current suggestions include period of no activity, an asymptomatic state, and normal blood enzyme levels before an athlete begins gradual return to play progression under direct medical supervision. Exertional hyponatremia. Each physically active person should establish an individualized hydration protocol based on personal sweat rate, sport dynamics, environmental factors, acclimatization state, exercise duration, exercise intensity, and individual preferences. Adequate sodium with meals should be consumed. Post-exercise rehydration should correct fluid loss accumulated during activity. Body weight changes, urine color, and thirst are cues for need of rehydration. Exertional hyponatremia is most common in endurance athletes who ingest excessive amounts of hypotonic fluid. Athletic trainers should educate athletes on proper fluid and sodium replacement. Athletic trainers recognize exertional hyponatremia signs and symptoms during or after exercise. If athlete's mental status deteriorates or if he or she presents with severe symptoms, IV hypertonic saline is indicated. Athletes with severe exertional hyponatremia should be transported to an advanced medical facility during or after treatment. Athletes with mild symptoms should restrict fluids and consume salty foods or small volume of oral hypertonic solution. Return to play should be guided by a plan to avoid future episodes. Exertional sickling. Athletic trainers should educate coaches, athletes, and parents as warranted about the condition. Athletes with known sickle cell traits should be allowed longer rest and recovery periods, adjusted work-rest cycles and environmental heat stress, and emphasize hydration. Athletic trainers should know signs and symptoms as well as the usual settings and patterns of sickling. Signs and symptoms of sickling warrant immediate withdrawal from activity. Non-rebreather face masks administering 15 liters per minute of oxygen should be administered. Athletic trainers should monitor vitals and activate an EAP if vitals decline. The athletic trainer must make treating physician aware of the presence of sickle cell trait. Head-down contact in football. Axial loading is the primary mechanism for catastrophic cervical spine injuries. Spearing is the intentional use of head-down contact. Football helmets and other standard football equipment do not cause or prevent axial loading. Technique is the main preventative measure for these injuries. Team education about this topic should be held at least twice per season, one before contact begins and other at the midpoint of the season. Lightning. The most effective means of preventing lightning injury is to reduce the risk of casualties by remaining indoors during lightning activity. When thunder is heard or lightning is seen, people should vacate to a previously identified safe location. Establish an EAP or policy specific to lightning safety. Nowhere outdoors is completely safe from lightning. People should remain entirely inside a safe building or vehicle until at least 30 minutes have passed since last lightning strike or last sound of thunder. Patients struck by lightning are safe to treat, but the area should be made safe from imminent lightning strikes first before treating. You must triage the first lightning victims who appear to be dead. Apply an AED and perform CPR as warranted. You will treat for concussive injuries, fractures, dislocations, and sudden cardiac arrest. Access to early defibrillation is essential, ideally less than 3 to 5 minutes from the time of collapse to delivery of the first shock. PPE should identify episodes of exertional syncope or presyncope, chest pain, personal or family history of sudden cardiac arrest, or family history of sudden death, and exercise intolerance. Sudden cardiac arrest is to be suspected in any athlete who has collapsed and is unresponsive. Airway, breathing, circulation, and heart rhythm via an AED should be assessed ASAP. Myoclonic jerking or seizure-like activity is often present after collapse from sudden cardiac arrest and should not be mistaken for a seizure. CPR is to be administered while the AED is being retrieved.